Peadiatric vestibular assessment. I familiar faces sitting here because I did deliver quite a similar talk on pediatric assessment 2 weeks ago when we held a pediatric vestibular masterclass in our program. Yeah, so it's maybe some repeats for some of you there. So epidemiology and prevalence of pediatrics is not only in Malaysia, all around the world. It's underreported. Some say it's only 5%, 3%, up to 8%. Some, I heard the latest one is about 30%, but I don't have the papers on slides here. Why underreported? Why discrepancies between centers or countries? Different issues. The expertise. When we're doing adults, it's not the same as doing pediatric. It's different. And then the technology that you use and the knowledge, or under-diagnosed. So the prevalence of balance disorders in children currently is reported still low, but it's increasing. Children diagnosed with these disorders typically do not present with chief complaint related to balance. Of course, they don't have the vocabulary to complain, right? How can they complain rasa pening? They don't even know what pening is. Pening, pusing, lawyer nak jatuh, pitam sikit kepala. Adult can say that, but children don't. With Malay terms, it's a bit confused. With English terms, it's easy. Dizzy, done. Nausea, done. Lawyer kan? Headache, kita headache, sakit kepala, pening, pusing. You know, faham kan? So it's not easy in children. So that is also rising evidence saying that significant associations between sensory neural hearing loss, despite the severity, mild to profound, are closely related with vestibular disorders in children. So in order to deal with pediatrics, understanding of the child is very important. We need to know their medical histories, normal versus abnormal development of the child. When we say the medical history, you need to look at the cases, and you need to determine whether they have any visual problems or not, whether they have any spatial problem or not, alright, balance problem or autoimmune problem. Autoimmune is arising. These shows that it has a connection with vestibular problem. So all this needs to be put together. Normal versus abnormal development, in order to say, oh, actually I'm observing that the child is not walking or crawling at the normal age. Normally we just say, oh, dia ada GDD ni, global developmental delay, ataupun lambat jalan sikit kan, abnormal, slow development, slow motor development. But we need to know the normal one as well. A different age group with different challenges, and the social interaction and communications ability of the child, of us, the professionals, and also the parents. So before testing, preparations and experience are vital. It is best to have a helper to help you in the clinic, and you need to anticipate the possible challenges in order to be prepared. And mentally, you need to decide what to do next, what test to start first, if you only can have the child with you to be cooperative for about 3 minutes. Right? So you need to be very flexible and able to put things together at the end of the day to deliver the results to the parents. So just now we have seen in adults, we have all those VNG, sakit, OPK, and also smooth pursuit. We do have that in children as well. Just look at this picture. This 28 months boy, 28 months, 28 bulan, diagnosed with GDD, hypotonia as well. The first time that I've seen him is after the first cochlear implant. He was implanted February this year for the first implant, and he had a second implantation July this year. to implantation. This is the first time I see him. He's just like this. Nothing can be done, but we take pictures, we take videos as evidence. Alright? He's very, very flaccid. When he came and see me, after the second implant, he has improved. Look at his improvement, yeah? Dia gerak macam tu, tapi when we put him the other way round on his supine, he is able to move his legs better. Last time tak ada langsung. Yang tangan pun dah gerak. That's an improvement. Right? And he's very jovial now.
Kalau letak dia badan ke bawah, dia macam mana?
He verbalize more because of the CI. In children, is no way that we can do VNG, right? How can we do VNG in such a young child? So we have a simple technique. Tengok ya. Ni buat test apa? Tak dengar ni. That's what? Apa tu? Okay, kata semua besut. Okay, IKIV the answer. Tengok dulu. Dia pandai tutup mata, tak nak buka, kan? So smooth pursuit, yes. To see his response. He follows. Important thing to note, he follows the response. Look at his eyeball. He really follows. Alright? He understands the task and able to follow. That's a good sign. Vertically, horizontally, he's able to. Vertical is not that developed yet in him. We noted that. Horizontally, yes. Vertical tak ada, not yet. Especially when going down, stimulus going downwards. These are using the OKN the smooth pursuit barrel, or OKN barrel. These are also to mimic the OKN, to force or simulate the nystagmus. So you're able to see its responses. The last one is sakat, using the little house, jumping ability of the eye to track. Alright? So we need to play with the kids. And take your time to observe the eye, record the eye. See? Tak dengar kan? Tapi yeah, we will just play with the child and see the OKN ability. Okay? The sakat ability as well. Okay. Look at this video. Look at his eyes very closely.
How are you?
Tengok mata dia ya.
How are you? How are you, Eden? How are you? Eden? How are you?
Can you see something?
Eden, look at mommy. Look at mommy. Look at mommy. Eden. Yeah. Looking at you. Yeah, Eden. Come, I think for you. Yeah, Eden. Yeah.
Can you see nystagmus? Yeah, at certain positions and directed induce, right? So we need to refer him to ophthalmologist first in order to rule out the nystagmus issues before we say that it's central or neurological, right? But his mother is very good. She's very observant, and she said, yeah, she noticed that earlier. That's the adaptations that we need to do in young children. So as an adult, we do have the BOT as well and MCTSIB, modified CTSIB test, standing on a cushion with eyes open, eyes closed, and walking heel to toe, 1 meter, and then have a 1 meter, 1 foot actually, and 1 meter walk. We have seen this just now, so I will not repeat. So the challenges in VAMS are the objective measures in children. Same principle as in adults, but different challenges. The screen preparations to scrub a young child is a headache. And then to determine the right positions to place the electrodes is a challenge because they have shorter neck. Shorter neck meaning that shorter SCM area, smaller SCM area. So you need to really identify the muscles in order to get optimal and correct response. Because if you put a trapezius muscle at the back, you still get a response. It's not coming from SCM, from SECU. I don't know where it comes from again, tapi mak akan dapat response juga if you place it at trapezius. For children, it depends whether you want to activate unilaterally with a head turn or bilaterally like this. It depends on the child cooperation. So when in children, when we want to rotate the head, it's easier. In a cooperative child, we just use handphones using light and ask the child to rotate towards the lights, and we got the response. And as you see just now, this is an easy child as well. But when it comes to these cases, as you can see, she is crying. And watch this video. This is not ideal. This is what we face in the clinic in young children. So, telling the parents what to do, how to hold the child. And now I'm trying to get the SCM muscles to be contracted. It's not turning sideways or lying on the bed and just tilt up the head. It's not going to happen in young children. We adapt a technique like a seesaw technique. The father push the child backwards, I push the child forward in order to force the neck to flex. By that, we're trying to get some SCM responses because it's being activated, and we see the secure response as well. But it takes a while to get this. This is an easy child. Same technique. I push the child backward, and he and the mother push or resist by pulling backwards. So we are forcing the SCM to flex as well. So we are also getting the response. Right? But the responses with bilateral activation, sebab macam straight kan, dia nak tak rotate, are not similar in terms of they have shorter latencies and shorter amplitude compared to unilateral activation. This is the EMG meter that I was talking earlier. So this is a visual reinforcer for the subjects, be it children or adults. So green is the good area where we need to achieve optimal SCM activations, and they need to we have to make sure that it's green all the time during recording. These are examples of CVAM responses, the good one and the bad one. This is unilateral loss, loss on the right side, optimal response on the left. So when it comes to OVAM challenges, child need to sit and look up optimally. So 4 years old will do, 4 years old in a normal cognitive child, and using mini shakers of B71. So this is what we have in our clinic, the responses. I just want to show you this one. This is not responses. These are artifacts of the mini shaker that we use. So in your clinic, you need to identify what is response, what is a true response, what is an artifact. Artifact tu maksudnya electrical artifact atau stimulus artifact lah. Yeah, it's not the true response. So in this boy, they ask the child to look upward, just looking up optimally, visual reinforcement. Pandang atas, pandang atas, pandang atas. No? Nampak kan anak mata dia naik atas tu, can see right, the eyeball going upward. So got the response. Okay, next is the VHIT challenges, goggle versus non-goggle system. We have used goggle before. It's ugly, messy, because it's not made for children. We cannot have any slight slippage of the goggles because of the small head size. They do have for pediatric, not to say goggles or inner sponge, but sometimes it's not small enough for our Asian children. Right? 6, 7 years old would be okay. Younger than that, it's not suitable. So the best system that we have is the goggle system. That's Synapsis one, the only in the market worldwide. So whereby that's how this test is being done. We just shake the head at the 3 different axes, the lateral, round and large, differently. See one more time. That's how we shake it and get the response. Okay. These are the interpretation. These are the tests. How the camera is there 1 meter away. So it's a fire wire system. The camera is here, and it measures or record the eye movement. And you can see from the stimulus and the response of the child. So we're able to get the response and see the eye movement at the same time. Okay. When VHIT comes into market about 10 years ago, many papers say that you need at least 30 averaging or 20 averaging. But the latest one in 2019 publication, August, which is last month, it has been agreed that reducing the number of impulses in VHIT is enough. The quality that matters, meaning that 1 or 2 impulses, especially young children, will do, and trustworthy response. But it needs to come from an experienced examiner or tester. The conclusion of the paper stated that these results indicated that 2 high velocity artifact-free clean impulses from an experienced testers are sufficient to evaluate the VHIT response in very young children. Further impulses do not improve the test reliability. So it's just 2 responses for each canal will do. Very quick. VNG and RC rotatory challenges I've mentioned earlier. It needs to be conducted in the dark and cooperation of the child. I'm not going to repeat this one. And the next one, the long-term consequences of us professionals who are unable to diagnose the children earlier with vestibular and balance pathology. We will not give them any chance for a better education attainment, and they're subjected to reduced quality of life, and more likely the cost and time for diagnosis will increase over time for late diagnosis. Especially in our country, we don't have a protocol to indicate that any children with hearing loss need to do vestibular assessments. But those are being implemented especially in European countries and US. Australia not yet. Also, the latest paper, not just latest, published 2013, but I like the reports here from Frontiers in Human Neuroscience. Personality changes in patients with vestibular dysfunctions are being reported, especially in young children. Depression issues, anxiety, behavioral problem, attention deficit, ADHD are being reported in vestibular pathology children. Also, there are convincing evidence that vestibular dysfunction may cause emotional and cognitive disorders in young children as well. So other challenges convince our team to take up the challenge to do the test, especially in young children. Because I love these two words when it comes to pediatric assessment. Passion, minat, and patience, kesabaran. You need both. Okay, I end my talk with 4 to 5 videos, short videos, for you to enjoy. Look at this first video of the same child. This I got this from the mom. He's crawling, right, months back. Following the ball because we want to encourage the child to crawl. And then he improves. He crawls using the chair. No ball. And only on the knee. Not using the hand anymore. Kan? Paling melunjur ke apa? Kan? Right? So it's improving over time in just 2 months' time. Next. We are happy. Not yet independently walking, but he walks, pushing the chair. Not on the knees anymore. And this was just like 2 weeks ago. So adaptation matters. Adapts. They do adapt. But if they have additional problems such as visual problems, somatosensory problem, that's a real big issue. If they only have solely the vestibular problem, adaptation is better. But if they become, in later stages of life, for example, they have chronic pathologies, okay, masalah contohnya diabetes, where we know that diabetic type 2 do have vestibular problems, then the vestibular problems might recur in later stages. Okay, higher falling risk. Another one of the videos that I love in our clinic. Tengok ya. Our implanted patients. She's 8 years old now, but this one when taken 4 years ago, 3-4 years ago. We just asked her to walk, and I'm waiting at the front. The parents are helping me. Look at the way she walks, and she needs to repeatedly go and stabilize herself. Kan? Menyandar kat dinding. Because she has balance problem. We don't realize this as much. But when I share this with my speech pathologist, speech language therapist colleagues, they say, oh, actually they see a lot of patients like this. But they thought it's just normal. No, it's not. It's not normal to walk a very short distance and you need to rebalance yourself every 2 minutes, I would say. Right? This is the easiest sign. You need to know this because sometimes when you meet parents, you need to ask, is your child clumsy? Selalu jatuh tak? Oh, selalu. Uneven surface or even surface? Even surface pun jatuh. Okay. Tersadung kaki ke? Tak. Tapi jatuh je. Then it brings question mark. Right? You can put all the information together with what you get during examination. I would like to acknowledge what I've got and learned, the techniques from Prof. Waina, from Hospital Robert Debré in Paris. I was with her last year, February. And with that, I thank you.